Hello, everyone. I'm Lillian Cao, President of Ifso, and I have the pleasure of welcoming all of you to our 17th Ifso webinar. I would also like to thank Reach Surgical for sponsoring this webinar. It is most appropriate that we are 21 years since the first laparoscopic sleeve gastrectomy, which was performed in New York by Dr. Michel Garnier. Dr. Garnier will recount that his first laparoscopic sleeve gastrectomy was by serendipity, the first of a two-stage approach for higher risk patients undergoing laparoscopic duodenal switch. Today, the laparoscopic sleeve gastrectomy as a standalone procedure has become the most common bariatric and metabolic operation in the world. So today's webinar will host the authors of the book, The Perfect Sleeve Gastrectomy, a clinical guide to evaluation, treatment, and techniques, recently published by Springer. This webinar will discuss the perfect sleeve. Is it reality or fiction? Attendees will have the chance to ask questions to the eminent faculty and learn all they need to know about this procedure. So please join me in welcoming our esteemed faculty. In order of presentation tonight, firstly, it will be Almino Ramos, our past president of Ifso from Brazil, followed by Dr. Patrick Noel from Dubai, UAE, and then Dr. David Knocker from Montpellier, France, Dr. Mariano Palermo from Buenos Aires, Argentina, and last but not least, Michel Garnier from Montreal, Canada. We also have two panelists with us, which is our past two president, Dr. Luigi Angrisani, Alfobi from the USA. So dear attendees, please sit back, comfortable, and be ready for some simulating presentations. At the end of the presentations, there will be opportunities for questions. So do send me your comments and questions so that our presenters can answer them. And I'll do my best to get through as many of the questions as time permits. So now I'm going to invite our first presenter, Dr. Almino Ramos, past president of Ifso from Sao Paulo, Brazil, to present on, is it really possible to do the perfect sleeve? Almino, welcome.
Thank you so much, Lillian. I think we have a nice webinar here. Can I have my slides, Manuela, please?
Yes, we can see your slide, Dr. Ramos. You may go on.
Yes, but I cannot. Let me see. Okay. You can see it?
Yeah.
Yes?
Yes.
Okay. So the perfect sleeve gastrectomy, that is a fact, that is possible, or just fiction? Is it possible to do it? I would like to thank Ifso for the chance to have this webinar here. Let's start looking for the definition of perfection. Definition 1. The condition, state, or quality of being free from all flaws or defects. Definition 2. The action or process of improving something until it is faultless. Definition 3. The manner or way that could not be better. We cannot do better than we just did. Definition 4. Flawless state where everything is exactly right. If we go to the next synonymous of perfection, I think that the best word should be excellence. But look, I think that in as exact science, as mathematics, as engineering, as physics, we can have an exact definition for perfection. But when we look for these three very famous paintings, and I will ask you, for you, which one is the perfect one? Probably we will not have consensus about that. Someone will think about Da Vinci, another Van Gogh, and even Monet. So you can see that the concept of perfection in painting is not exact. And if we go for cars, probably will be the same. Someone will prefer Ferrari, Maserati, Lamborghini, Aston Martin, and other brands. So again, it's important to say that perfection will depend on your personal view, is something subjective. So yesterday, and I want to thank Harry Squasha from IBC, because yesterday I discussed with him about doing a poll with the surgeons in IBC to discuss if it is possible to do the perfect sleeve gastrectomy, because we have some controversies here. Some surgeons think it is, another that we cannot do the perfect bariatric procedure. But in this polling, we had as answers that 41% of the surgeons think that it's wrong. It is 61% of the surgeons think that it's possible to have a perfect sleeve gastrectomy, and 39 think that is not. So it is 61 pro and 39 against. So let's see. This, for me, this is my definition based in my experience in bariatric surgery. This is my definition of a perfect sleeve gastrectomy. I have these 11 queries, starting 3 to 4 centimeters from pylorus, calibration 32, 34 French, straightforward stapling, adequate choice of the cartridge, of the staple height, reinforcing the staple line, doing omentopexy, a total resection of the fundus, keeping a distance about 1 centimeters from esophagus, with no torsion, no kinking, no bleeding, no leak, and no perioperative incidentals. So the other discussion is that we are talking about the procedure. We are not talking about the result, because this is not the way that we are looking right now. I mean, looking about the technical systematization only. If we discuss result, I think that will be a different discussion about perfection. So look for this video. This is one of my procedures. This is a very short video. We are starting the greater curve division. And so we go up and we go down in the greater curve in order to have the total liberation of the stomach. We are removing some additions in the posterior part of the stomach. As I told you, I prefer to reinforce, so I'm using Singward. If I can use, I prefer to use. I cannot use in all my cases, but if I can, I use. You see that I am looking for the perfect tube, looking posterior. We have started with a black cartridge. Now it is green, and we go for gold, and we go for blue. We change the staple heights as we go in moving in the sleeve. We are getting close to the esophagus, and that's important here to be a little far from the esophagus. As I told you, we look for 0.8 or 1 centimeters here. And with this, we finish the resection of the stomach. And again, for me, it is important to do the omentopexy. So again, this is subjective. For some of you, it's not important to do the omentopexy, but for me, it is. I learned over my experience that it's important to keep the stomach in the position I want, avoiding adhesions and avoiding torsion. And now removing the specimen from the abdomen. So we could see step by step the way that I consider for doing a perfect sleeve gastrectomy, methylene blue test, removal of the tube, and with this, we finish the procedure. So again, considering the queries that I create for evaluate my operation, the 11 queries again, for this case, I think that I can evaluate that this, for me, in my way of thinking, it is a perfect sleeve gastrectomy. So based on my experience, considering my 11 queries to evaluate my sleeve gastrectomy, that one I could classify as a perfect sleeve gastrectomy. So answering the question, it is really possible to do a perfect sleeve. My answer is yes, but this will be based in your personal experience. So I will finish inviting you for something different. This night in Brazilian time, 9 p.m., we will do something different. I did the same last week with Antonio Torres. And this night we will have a live interview with our great Professor Malfoy by Instagram, trying to do something different of our regular webinars. Let's see his 40 years experience in bariatric surgery. Thank you so much for your attention.
Thank you, Elmino. That was a good presentation. We've learned the 11 steps to making the perfect sleeve. Now I'd like to invite Dr. Patrick Noel from Dubai, UAE, to tell us about preparation, selection, and outcomes. Welcome, Patrick.
Sorry. Can you hear me?
Yes, please go ahead, Dr. Noel. We can see your slide and we can hear you.
Okay. So preparation of the procedure is something we know that, like every kind of procedure, obesity is a multifactorial disease, and this multifactorial disease needs a multidisciplinary team for complete assessment, as like you know, with nutritional, clinical, biological, psychological, metabolic, with some complementary exam. A few years back, ACE-MBS published an evidence care pathway for sleeve gastrectomy with some routine, some selective, and some recommendations. You know that in different countries with different societies, some exams are mandatory, others can be proposed to for some patients, like endoscopy, even if I think, and we all think that it's really important to do an endoscopy before a procedure. So preparation is like for every kind of bariatric surgery. Selection of patient is very important and well described as well in the book by Rami Lotfi. And as you know, just obesity is something difficult to define. There is some subjective feeling. And today, sleeve, as you mentioned it before, is now the first procedure performed worldwide. And probably because we touch only the stomach and for the patient, it did a huge difference. We don't touch intestine. And with this restrictive effect, we'll add a hormonal effect. This is why for many surgeons, almost two surgery on two worldwide are now gastric sleeve. So I want to focus on some particular scenarios. For me, we have to choose sleeve instead of other procedure. For young and older patients, if there is still a debate for all indication, like you know, and because obesity is a progressive disease like diabetes, we will have to escalate sometimes the treatment. And when we start the first surgery like a sleeve, it's easy sometimes to do a second procedure a few years later. And same for older patients, the quality of the surgery, the safety of the procedure are major arguments to choose a sleeve. Sometimes for technical reasons, when you have a lot of adhesions, it's easier to go for a sleeve. Same for patients with a high surgical risk, heart failure, respiratory compromise, it's probably better. Patient under anticoagulation, and in some countries, some endemic areas with risk of gastric cancer. So special indication has been developed in the book by Almino and Eduardo Bastos from Brazil, with some indication, specific indication like with cirrhosis. We know the liver damage associated with obesity. And when you lose weight after a bariatric surgery, like for steatosis, inflammation, fibrosis, you have a huge improvement or resolution of the liver conditions. And we know as well that cirrhosis is associated with a higher morbid mortality rate after a major surgery. Another reason to choose, I think, sleeve instead of the procedure with bypass. When you have to deal with inflammatory bowel disease, same probably sleeve is much better. And same another indication is before transplantation. We know that the surgeon doesn't like to transplant organs with obese patient. And if you do a sleeve, you can then easily go to a liver transplantation or heart transplantation when after your patient loses a maximum of weight. Another reason, we know that obesity and diabetes are the two major factors associated with reduced post-liver transplant survival at 5, 6, 7 years of follow-up. Now we have some contraindication and probably limitation, even there is still a debate. You know, there is one weakness with sleeve, like I think with many other bariatric surgeries, the weight regain. This is something we know, but as I told you, with bypass is same. We see sometimes patient regain weight, and the surgeon has this part of the job to do, but the patient should maintain the result. Same, when you have diabetes, severe metabolic syndrome, sleeve has shown its efficiency recently in different randomized clinical trials without any statistical difference with a gastric bypass, even if sometimes weight loss is slightly better with bypass. And last, the key point is probably now the debate with sleeve and GERD, and David Noka will treat this issue later, but we consider now that Barrett esophagus is probably a contraindication to do a sleeve, even if GERD, acid reflux, is not a contraindication to do sleeve. I will conclude with a word of Rami Lutfi in the book. Sleeve is a safe and effective metabolic procedure that earns a well-deserved spot on top of all available options. In the right hands and for the right indication, sleeve should be the first procedure of choice in the battle against the chronic progressive disease of obesity. Now, last chapter, the outcomes, well described by Luciana Cadre from Brazil. Sleeve was considered, as you know, as a restrictive procedure, but will have some hormonal effect. And you have some nutritional recommendation for patients submitted to sleeve. And this chapter will highlight the main cause, prevention, and treatment of all deficiency we can see after sleeve, like without surgeries, with all kinds of vitamin B1, B12, some anemia, iron, bone, and others. The prevalence of nutritional deficiency with sleeve is summarized in this slide, and we have almost 30 to 70% of deficiency of vitamin D, B12 10 to 20, thiamine, iron 15 to 45, and calcium, folate, copper, zinc. So we have to follow our patient. We have first to assess our patient before the surgery, mandatory, and after the surgery, and we can propose this suggestion with a complete follow-up 1 year, 2 years, and later with time. This is really important to check and to evaluate our patients. Result in weight loss and improvement of comorbidities with weight loss. We have data now with long-term excellent result after sleeve. And as Almino told before, there is technical factors to respect, like probably Bougicide, a proper technique for a perfect sleeve. But we know as well the quality of the intake on patient is determining as well. With diabetes, I mentioned before, we have a lot, 3-4 RCT today, Stampede Sudai at 5 years, sleeve past, both RCT, and all showed excellent and equivalent result with sleeve regarding diabetes, and there is no difference with bypass. Even sometimes there is a small difference in terms of weight loss. With sleeve apnea, hypertension, and dyslipidemia, as well, we have very good result with sleeve gastrectomy. Thank you, merci, shukran.
Thank you, Patrick, for a succinct presentation on preparation, selection, and outcomes of sleeve. We'll move on to our next presentation. It will be from David Knocker from Montpellier, France. As we know, sleeve is associated with reflux, and therefore Dr. Knocker will tell us about controversies regarding GERD and sleeve in his presentation. Thank you, David.
To be there with you during this very nice webinar. So I will try to present some slides about controversies and about GERD and sleep. You know that it is a main topic concerning the morbidity of sleep today. My disclosure are here, another disclosure, and that I prefer sleep. Considering obesity and GERD, you know that a lot of obese patients present GERD. 15 to 50% of patients in the literature have symptoms, and we know that probably more due to patients who don't present symptoms but had a positive gastroscopy. What is really strange is that we don't really care about this type of patient. I mean, the control in endoscopy, the care of this patient is not very famous. So I think sleeve has emphasized the problem of GERD and the need of follow-up and of treatment for GERD. If we look at the literature, there is national analysis in JAMA 2014. What is really interesting in this study is that the new onset GERD is around 8.6%. And the other point is that if you are doing a sleeve on patient with a previous severe GERD, the results are not so good compared to bypass. But if you are doing a sleeve for a patient without reflux, the results are really great. You know that 2 years ago we had three articles that describe a real high rate of Barrett's esophagus after sleeve. Janko, Sebastianelli, and the team of Praga in Austria describe a rate of Barrett's between 15 to 18% of Barrett's. So a lot of surgeons has been a little bit worried about this point, and it's normal. But there were several bias in these three publications. I mean, the rate of dysplasia was nil, and you know that the definition of Barrett's is not so well known for some surgeons, and it's different in some countries. I mean, you need to have intestinal metaplasia if you want to speak about Barrett's, and in these articles we have no explanation about the Barrett length and about the intestinal metaplasia. So probably it is a little bit high in terms of percentage of Barrett's. Most of the others publication are describing a rate between 5 to 6% after sleeve. The risk is to have an esophageal cancer, and you have seen the literature. There is very few cases of esophageal cancer. And I have to be honest, we have more cases of esophageal cancer during the checking part of the endoscopy before the operation than after the sleeve. So I think we have to promote the gastroscopy before the operation, and after we will speak about it. Another point that is very important is that we know how to treat the Barrett's esophagus. Everybody is afraid about Barrett's, but we have the possibility today, due to excellent increase of new techniques, endoscopic techniques, to do a radiofrequency, to do endoscopic mucosal resection. So we can use it if we have a good follow-up of the patient and a good endoscopic follow-up. So I think we have many possibilities to prevent with PPI or to treat with radiofrequency and endoscopic mucosal the degenerescence of Barrett's esophagus. So that's a great point to try to decrease the pressure on sleeve and Barrett's. We have done 1 year ago a fantastic meeting in Montpellier with more than 50 bariatric experts, and we tried to give some recommendations about GERD and sleeve. And one recommendation is to follow the patient. And I think there is some surgeons who are not aware of that, but you really need to follow your patient by gastroscopy. I think that we are not all agree about the delay, the time of the follow-up, but after 1 or 2 years, I think the patient has to be an endoscopy. So, is GERD and sleeve already the problem of the past? I will tell you why. Because in Montpellier we are trying to improve the technique of sleeve since 5 years, And we have described the Nissen sleeve gastrectomy. And this operation promotes the creation of fundoplication or total fundoplication that will be made on the lower part of the esophagus. And you will see that this operation is possibly the perfect sleeve of the future. Why? Because we have the same excess weight loss at 2 years. So in midterm follow-up, 71% of excess weight loss. Even if you let in place a bigger part of the fundus in order to create the fundoplication, you have the same excess weight loss. It works on GERD symptoms. When you ask for questionnaire for GERD after sleeve, after 1 year, 90% of patients with a previous GERD, that's very important, had no symptoms. And if you look at the morbidity of the operation, we had a very long learning curve to finally find the good way to do it 2 years ago. So we have the new data on the trial, the prospective evaluation. And between January 2018 and December 2018, 103 patients, no mortality and reoperation rate of 2%. However, I have to emphasize that in 2017, I tried to simplify the technique in order to spread it more easily. And this operation is not easy, for sure. I think you need to be an expert to do this operation, because when you have to deal with the hiatal hernia in a very huge patient, when you have to create a fundoplication, I think you had some tips and tricks to understand and to have good skills to do it. So I think this operation has to be spread for the expert first, and then we will evaluate the long-term data. But what is sure is that you have less GERD, less than 10%. After long-term follow-up, I will publish in September the 5 years follow-up for the Nissen sleeve. Another point is that you have less leakage at the east angle because you have the fundoplication. So you will not have the long-term treatment of chronic fistulas that we'll have with the sleeve. And I think that surgeon and bariatric experts are more open-minded today because they have seen the need of something that can improve the result of sleeve and about GERD. And during the consensus summit, 73% of the experts have validated the option to perform an anti-reflux procedure to prevent or treat GERD during bariatric surgery. So I invite you in Montpellier if you want to be teach to see how it works. I think you need to see 4 to 8 procedures. So feel free to contact us, and in September I think we will reopen the workshop courses in order to help you to do this procedure. So my conclusion is that sleeve is the most performed bariatric procedure in the world because it is efficient on weight loss, it is a lower rate of morbidity, and there is several options to prevent or manage GERD. So that's why it's a problem. We have to be honest to have so many patients with GERD after sleeve, because some patients need to have a bypass after that. But I don't want to forget, and you to forget, this point. If you look at the complication of sleeve compared to bypass, I prefer to have GERD symptoms and give PPI than to have internal hernia all the long life with a very high rate, 5 to 7%. To conclude and to thank you, I invite you to follow the eBest Congress with Michel, Patrick, Nilton Kawara, and Mariano and Almino, Marius Nedelku, and 46 experts. We'll try to do a 24 hours of live bariatric surgery. It will be live recorded because it's not possible to do a total live surgery. But I think it will be a very nice day to share, and you will have all the tips and tricks of all these great experts that will show you how to do all the operation, not only sleeve, but bypass and BPD and SASI and all the new procedures. So thank you another time. Thank you to the Ifso team for the organization, and thank you to all my co-author of the book. It's an achievement for Michel Gagné, and Michel, I want to thank you another time, because if we are here today, it's due to your hard job. Thank you very much.
Thank you, David. That was a very eloquent presentation, and we look forward to your eBest workshop from Montpellier. Next, I'd like to invite Dr. Mariano Palomo. As we know, there's no operation without complications, but Dr. Palomo is going to tell us how to prevent and treat complications from the perfect sleeve gastrectomy. Welcome, Mariano.
Hello, good morning and good evening to everybody. Thanks, Lilian. My talk will be about prevention and treatment of complications. I have nothing to disclose. First of all, I would like to thank Ifso, and it is an honor for me to be with all these presenters and panelists. It is really an honor for me. I will focus my following 10 minutes in these 3 chapters of the book: the prevention and treatment of bleeding, the classification of leaks and fistulas, and I will detail a little bit more in this chapter 25, that is the image guide percutaneous abdominal procedures following leaks after sleeve gastrectomy. We all know that bariatric surgery and also sleeve gastrectomy nowadays is a very safe procedure, but of course it has complications. Fortunately, the rate of complications is low, but we know that the potential complications can appear, and we have to treat them quickly. The faster we treat this kind of complications, the better. If we classify the complications, we can have leakage or infection. These are very close. That's why I will talk about them together. Bleeding, and I'm not gonna talk in this part of strictures, but strictures after sleeve or torsions are another kind of complications. When we talk about intraoperative bleeding, we have some technical factors regarding the gastric vessels that here, when dissecting the greater curvature and the short vessels, as Almino told in his first talk, it is important to completely apply all the vessels before activating the energy device in order to prevent intraoperative lesions. And traction here is very, very important, because the traction will allow us to have a good visualization of all the tissues. Another intraoperative bleeding that we can have during the sleeve gastrectomy is the staple line bleeding, and here a mismatch between the staple height and the thickness of the tissue may lead an incomplete staple formation, and a staple line bleeding or leak can occur. Almino told us in the first talk about the different staplers and the colors, and here it's very important to follow that. And when we talk about staple line reinforcement reduces the incidence of bleeding. It is not very clear if it reduces the leak, but yes, the bleeding, and that was described by Shikora in his meta-analysis 4 years ago. Regarding the postoperative bleeding, when we have post-op bleeding, we have two options: intraluminal bleeding, that the intraluminal bleeding is going to be treated by endoscopy, and extraluminal bleeding. Here, if the patient is stable, we can perform a CT scan, and if the CT scan shows us a large hematoma or free fluid, a laparoscopy can be performed, and if we can do a conservative treatment with small hematomas, that's another option. But of course, the leakage is the worst thing we think we can expect after a sleeve gastrectomy. And Dr. Bosa, in his chapter of the book, classified the different types of leakage according the time, according the clinical presentations and radiological findings, the clinical presentations, and extension of the dissemination, and of course the location. We all know that the proximal third of the sleeve is the one that will have more problems regarding leaks. I strongly think that all these kind of complications should be treated by minimally invasive surgery. When we talk about minimally invasive surgery, I talk about flexible endoscopy, laparoscopy, or interventional radiology. In Argentina, we call percutaneous surgery. And we all know that when we have early surgical complications and when we find these cases with free fluid, a laparoscopy with suction of the fluid, washing, drain, we can do stitches, we can do stapler of the lesion. But when we have late surgical complications, here all the minimally invasive procedures regarding percutaneous surgery can be achieved. So if we go a little bit back through in the history, we know that in the 16th century, the barbers were the surgeons, and they only do treatment. After that, in the 19th century, the open surgery was the diagnosis and then the treatment. In the last century, the minimally invasive procedures developed very, very important with the laparoscopy, the percutaneous surgery, and the endoscopic surgery. And now, and there we have the diagnosis, and we have to choose a tool for the treatment. And of course, it's very important the follow-up. And now and for the future, I think these all minimally invasive procedures with image-guided surgery, with augmented reality, with Indocian in green, will allow us to treat all these patients in a better way. As David told regarding the complications when comparing a bypass with sleeve, we know that bypass has more rate of complications and reoperations than sleeve. This was published in Journal of the American College of Surgeons several years ago. And when we talk about leaks after sleeve gastrectomy, in this multi-center experience with almost 3,000 patients, we can see that 1.5 of leaks are acceptable. And in that paper, they say that the mortality for leaks is very low, it's 0.1. But if we dissect a little bit more this trial, we can see that the real mortality for leaks is higher. So that's why we have to identify these complications and treat them quickly. Last year, we published in Obesity Surgery our experience in image-guided procedures after bariatric surgery. And in the book, we have this chapter published with Dr. Mariano Jimenez, where we focus on the minimally invasive treatment and all the percutaneous and image-guided procedures following leaks after sleeve gastrectomy. When we have this kind of abscesses, the first thing we do is to drain these patients. We do under CT scan guidance, and we place this kind of catheters that are called the pigtail drains, and sometimes we have to use atypical approaches. Here we can see that we pass through the left liver. That's because the collections are high, and this is complex because the patients are still obese. And other examples, these big collections after sleeve gastrectomy with fluid and air inside. And with a transcostal approach, we placed this pigtail drain, and the patient underwent well. As I told you before, these kind of procedures are complex because the patient is still obese and the fluid collections are very high and subdiaphragmatic, and this increases the morbidity and of the procedure. 65% of these cases goes well with this kind of treatment, but for the rest, we have the endoscopic options with the use of stents or the use of different clips. For example, these Ovesco clips, and we have many other stents that we can use. We also have fistulas with no fluid collections, and here we don't treat infection because there's nothing to treat, but we just place a cover stent under X-ray guidance. With Michel Gagnier and Nelson Treyes, almost 11 years ago, we published this case at Cornell University. We can see this was a patient that underwent a sleeve gastrectomy, then due to weight regain, a rest sleeve gastrectomy, and the patient in the rest sleeve have this fluid collection with air and a gastrocolic fistula. This patient was treated with a catheter with interventional radiology and an endoscopic stent. The patient underwent well, and the gastrocolic fistula was solved. What happened when we have an intermediate cavity? When we have an intermediate cavity, we have to drain it. Look at here, we have the primary orifice, then the traject, and then all the intermediate cavity. What we did in this case was through the catheter, we passed a guide wire to the intermediate cavity, another guide wire to the small collection that was very close to the fistula. The patient was treated first with a stent, then that the stent didn't work, and we placed these two catheters, and the patient underwent well. A couple of weeks after, the drains were removed, the fistula closed, and the stent was removed too. What happened when we have collections and no fistula? Of course, the first treatment for us is the percutaneous drainage, and here we don't have fistula, so the follow-up of the patient is better, but the drainage is still complex because the collections are very, very high, and sometimes we have to triangulate in the CT scan with a ultrasound machine in order not to make lesions of the lung. So we know that when we talk about general percutaneous interventions, 6% of complications are allowed. When we talk about complications of percutaneous drainages following bariatric surgery, we have more than that. We have almost 23%, and that's because the patients are complicated and the patient is still obese when the complications occurs. So summarizing, when we have an acute leak or an early leak in stable patients, we can think about laparoscopy or percutaneous drainage, but with unstable patients, we go directly to a laparoscopy, wash, drains, etc. And for late or chronic leakages, we use the percutaneous drainages to treat these patients. So, for conclusions, I think percutaneous procedures have an important role in the treatment of complications after bariatric surgery, mostly in those late or complications. They are safe and effective, but as I told you before, the fluid collections are central. The patient is still obese, so that's why the complications increases when comparing with other percutaneous approaches. And here I think the multidisciplinary approach has to be the goal, as all in bariatric surgery, but here working the endoscopists, interventional radiologists, and bariatric surgeons. And I strongly think that bariatric surgeons have to know about interventional radiology procedures to treat their own patients. My final take-home message is that we know that obesity is increasing and will increase more and more in the following years. That's why bariatric surgery will increase more. Despite they have low morbidity and mortality, potential complications can appear. They have to be treated quickly, and these options, I think, are the most important for the treatment of these potential complications: interventional radiology, endoscopy, and also laparoscopy. This is our team in Argentina. I would like to thank every one of them. And again, it's an honor for me to publish this book with Patrick, with Michelle, with Almino, and with David, that they are, for me, masters, and no masters, they are friends. So thank you so much.
Thank you, Mariano, for a great summary on how to prevent and treat complications. Now, while we all strive to do the perfect sleeve, we know this is not always possible. So I'm going to invite Dr. Michelle Gagne, who has taught us how to do the laparoscopic sleeve gastrectomy. What do we do with an imperfect sleeve? Thank you, Michelle.
Thank you very much. Can you see me?
Yes, we can see you.
Okay, good. You can see my slides. Okay. Well, thank you very much. I want to thank Ifso and Manuela for the opportunity to present this new book, as well as Dr. Cao and panelists for allowing this to happen and to participate. And I want to thank my co-authors, editors, Patrick, David, Mariano, and Almino, for participating in this book as co-editors, and also all the collaborators who participated in the different chapters. And special thanks to Mariano, who has been coordinating with the publisher to accelerate and really publish this in a record time. So I'm going to present to you data that has not been officially published. The first study is the revision surgery after sleeve gastrectomy, and this is a nationwide study over 10 years. This is from a team from Créteil in Paris, or near Paris, and they've looked at 224,000 sleeves. And the revision over time, as you can see here, will go from 4.7% to 12.2% by the 10th, 11th year. A history of gastric bending is pretty bad, because some patients in France had gone from gastric bending to sleeve, and those had a revision rate of 20% or so. The revision procedure in France, and I think it's not any different in other countries, has been, in 3/4 of them, a gastric bypass, followed by a re-sleeve in 18.7%. You can see here over time the percentage, and if we break down this over time, you can see that if there was previous bending, the likelihood of revising the sleeve later is much higher than if there was no previous bending. By the 10th, 11th year, as you can see, it's between 12% versus above 20% for previous bending. There are factors that increases the revision of a sleeve. Female sex, it appears that if you do a sleeve on a male patient, you have much greater chance of success. And this is interesting and probably related to the ratio of stomach removed to stomach that is left in place. And this is a much better ratio for male patients versus female patients. Also, body mass index more than 50. So super obese patient is a factor for revision of a sleeve. Now, this brings a point in the study that perhaps some patients were in fact 2 stages, and they were not accounted as such as a 2-stage, but rather as a revision, which is giving a false statistics of revision. Again, a common history of previous bending, but because bending now is less than 1% in North America, this is unlikely to be seen in the near future. Type 2 diabetes is also a procedure that will get revisions. Now, some of the highlights, as I said, it's at 10 years is revision is about 12%. Again, 3/4 of them are Roux-en-Y gastric bypass. The reason for revision has been persistence of obesity in 87% or nearly 90%. And for reflux, it's the minority of patients that get revision for reflux. This is important to notice. Now, they do mostly Roux-en-Y gastric bypass, and look at the leak, 5%, 18% of bleeding, and reoperation for problems is 6%. So most of these patients have not had a re-sleeve, but rather a Roux-en-Y gastric bypass. So of note that revision is a bit risky. So my take on this about to be published paper is that body mass index more than 50, in my opinion, should be a 2-stage procedure, and the patient should be told that this is a 2-stage procedure, super obese patient or super obese patients. But you know, a surgeon will not necessarily discuss this, agree to do a sleeve, and then the patient ends up with a revision 5 to 10 years down the road, and this is counted as a failure of the operation when in fact it should be a 2-stage. And in France, those was not counted as 2 stages. Roux-en-Y gastric bypass for body mass index more than 50, in my opinion, is also a problem. As I was trained at McGill University, and Lloyd McLean a long time ago showed that Roux-en-Y gastric bypass and body mass index more than 50 gives 40% failure rate. So we're not far from sleeve having the same failure rate as Roux-en-Y gastric bypass for super obese patients. And I think in France, 87% decided for a revision for weight loss with the Roux-en-Y gastric bypass. In my opinion, this is not the best strategy. If we look at this paper, looking at residual gastric volume after sleeve gastrectomy, we can see that at 1 month, the whole reservoir is about 124 milliliter, and 1 year later, it has increased to nearly 200 ml, and that is the normal physiology of the stomach increasing its capacity over time. We see this in Roux-en-Y gastric bypass, and we see this also with sleeve gastrectomy. And this increase is proportional whether we're talking about the top of the sleeve or the antrum. So it's uniform in its increase usually. And if we plot the gastric volume change, that is increase in gastric volume over time versus the percentage of excess weight loss, we see that it is correlated. Increase in gastric volume over time cause a decrease in percentage of excess weight loss. And we note from Dr. Himpens in his landmark paper in the Annals of Surgery that the percentage of excess weight loss over time decreases. And this is attributable to some fundus that stretched over time. But in my honest opinion, at that time when those cases were done, the fundus was not fully dissected. And I think you can see on the top portion, this is a slide that I've done in 2011 and not changed my technique. The fat pad has to be dissected to see the junction of the esophagogastric junction, not only to see, but also to realize if there's a hiatal hernia that should be repaired. And that's probably 1/4 of patients should have a hiatal hernia repair. And this fat pad being dissected, then we remove this triangular fundus excess that a lot of surgeons leave in place, and this will dilate over time and cause a failure. In 2003, we had published on re-sleeve, and we think this is a good strategy that caused a reduction of 7 to 10 points of body mass index. It's not a difficult operation in that you put the bougie and then you again remove the excess on the left side of this bougie. Dr. Nedelcu Noel had republished a series of data on this, and the indication for re-sleeve was poor weight loss in 53% and weight regain in 42%, and the estimated volume was 388 ml pre-sleeve. And you can see some of the volumetric CT scan showing here a distension of the fundus as a primary and a secondary where the whole sleeve is dilated, and that's usually most of the cases. And the algorithm is that if there is a primary or pouch dilatation on the top, that re-sleeve is proposed. If it's a uniform dilatation, it depends on the volume. If it's more than 250 ml, then it goes for a re-sleeve. If the patient has reflux, and reflux is the majority of the problem, then the patient gets a Roux-en-Y gastric bypass. But if the distension is less than 250 ml, then the patient is not a good candidate for re-sleeve, but rather for a CD operation. And you can see that post re-sleeve in that paper, the body mass index goes below 30. Now, this is again unpublished, but about to be published. The 5-year result of this re-sleeve, those 52 re-sleeve patients, shows that at 5 years, the body mass index is at 30, which is quite sustained over time. And if you look at other authors, this may vary between 59% to above 70% of excess weight loss. So re-sleeve is effective and durable. I think it is around 60% of excess weight loss. It's best if the initial body mass index was less than 50. It has an acceptable complication rate. And of course, we may need to do some randomized study comparing it to another operation. Now, there was a meta-analysis that is again about to be published, and this is from Milan. And this meta-analysis looked at a series of 300 patients. This is the abstract, but I will break down for you 300 patients, 10 studies over 10 years, 81% are females, and a follow-up up to 132 months after the sleeve. It takes only 51 minutes to complete. The caveat here is that there is an increased leak rate with re-sleeve, with less tissue having blood supply. 7.6% of complication and hospital stay is 3 days. The result of this meta-analysis show again a 62% of excess weight loss, and it's quite promising. Option number 2 is to do a CD operation, and again, this is unpublished data, but about to appear in SWORD from the team of Dr. Pernotte and Dr. Torres, the CD after sleeve gastrectomy. In their series at 5 years, you can see the body mass index getting over, the percentage of excess weight loss over 75%. If we break down a body mass index less than 50 at 5 years, the percentage of excess weight loss is almost 100%. This is quite fantastic and awesome, but super obese patients get their body mass index, their percentage of excess weight loss, close to 70%, which again states that this is a much better strategy than for a Roux-en-Y gastric bypass. Another interesting study is the comparison of single anastomosis compared to one anastomosis gastric bypass. This is unpublished data about to be published. And CEDI versus single anastomosis gastric bypass after sleeve gastrectomy. This is 42 patients in each group. It wasn't randomized, but very comparable. And you can see here that by the time we reach 3 years, that CEDI is giving, there's a trend towards better weight loss with CEDI versus single anastomosis gastric bypass. Here you can see and appreciate. Now, the procedures performed simultaneously. This is interesting that in single anastomosis gastric bypass, the hiatal hernia repair was performed more frequently, while the gallbladder operation was performed in CEDI for fear of gallstone problems. If we look at the problems, complication, or you noticed here that about more than a quarter of patients develop symptomatic bile reflux in single anastomosis gastric bypass. This bile reflux or symptomatic reflux was only 4.8% in CEDI. So it appears that readmissions were close to 43% in single anastomosis gastric bypass versus 23% in CEDI. So I think in the long term, CEDI is going to be better than single anastomosis gastric bypass. And finally, this final study, this is the only study that is officially published, but I want to remind you that why I think Roux-en-Y gastric bypass for weight loss after sleep is not a good option. And this is a multi-center cohort study that compared single CEDI versus Roux-en-Y gastric bypass. And you can see that it really diverged from the get-go at 1 year, and then at 2 years, it's even worse, where single anastomosis gastric bypass gives a percentage of total body weight loss above 40%, while with Roux-en-Y gastric bypass, if you look at the sleeve when they got reoperated, it's only marginal improvement in this Roux-en-Y gastric bypass. So Roux-en-Y gastric bypass is a deception if you think that it's going to help patients after sleeve gastrectomy. And we look at post-CEDI versus post-Roux-en-Y gastric bypass on vitamin deficiencies. And it's interesting that vitamin B12 was important deficiency in Roux-en-Y gastric bypass, but none in CEDI. The rest of the vitamin deficiencies were very similar between the two operations. So I have to conclude on the Roux-en-Y that it is not such a great option for weight regain after sleeve gastrectomy. So my conclusion slide is for the imperfect sleeve with weight regain, dilatation of the sleeve with an initial BMI less than 50, especially with a volume of more than 250. I think re-sleeve is coming out as an adequate operation, especially someone that wants to avoid intestinal surgery with its associated micronutrient problems. If there's weight regain without dilatation, then I think that, or if there is type 2 diabetes that has reappeared, then a CEDI is the best operation, in my opinion. For GERD, for severe GERD, someone taking PPI, I think Roux-en-Y gastric bypass is the only good option. And unless in the near future there will be links or other things. But body mass index more than 50 with super obese patients, it's mostly CEDI. And perhaps in the super obese patients, perhaps a duodenal switch may have a role, but randomized control trial between CEDI and DS are ongoing, and we might see the best candidate for a DS in the near future, but I think it will remain small. So thank you very much again for participating in this webinar, and thank all my collaborators and co-editors of the book.
Thank you, Michelle, for sharing your vast experience. Attendees, we have been treated to a summary of the newly published book on the perfect sleeve gastrectomy a clinical guide to evaluation, treatment, and techniques by the esteemed editors of the book. Now, this book is available through Springer as a hard or electronic copy. We have two very experienced surgeons, past presidents of Ifso as our panelists, Dr. Luigi Angrisani and Dr. Mel Phoebe, and I'd like to invite them to give their comments. Firstly, Luigi, I think you've got a presentation that you'd like to share with us. Go ahead, Luigi.
Hello?
We can hear you, Luigi.
Can you see me as well?
We can see you as well.
Good. Okay. Thank you very much, Lillian, and all the invited and presenting people here this afternoon. It was, first, let me congratulate for the excellent book that I have entirely read from the first page, and the very nice introduction from Rubino, because it was, I think that introduction is very nice. I like it very much. And let me say that I have a few comments for each of the panelists. Let me skip on Mariano Palermo. I would completely agree with him on most of his view on preventing and resolving the complication. And the other person I want immediately to address my comment is Professor Gagné, that in his 60, getting old, he gives the best of himself. I appreciate very much his presentation. And for him, I have two observations. One is that he says that for a complete fundectomy, it is absolutely necessary to go and see, of course, the esophagogastric junction. And he says that a quarter of the people who receive sleeve gastrectomy need to have a complete dissection for a possible hiatal hernia, just to accomplish the perfect, let's say, the perfect fundectomy that is very important to do the sleeve. I agree with Michelle, but in my experience, as I will address later, is probably more than 25%, for probably more than 50% of the sleeve I do. And the other comment and question I have from Michelle, of which I, let's say, I follow completely the main concept and strategy, is my question is when he does the Roux-en-Y gastric bypass or a failed sleeve, if the sides of the biliopancreatic limb are different. In other words, when we do a Roux-en-Y following a failed sleeve, that in my case, quite often the failed sleeve has also symptoms of reflux. So you have a combination of reflux and weight regain. In that case, for me, the indication is Roux-en-Y with the 200 centimeter biliopancreatic limb and an 80 centimeter alimentary limb. But of course, I want to hear his opinion on that. Going to Patrick Noel, I have a question for him regarding the indication. I've read in his chapter, and I've read the indication of the book. I may have missed, but I don't think. I want to know if there is indication for a sleeve following liver transplantation, if it is indicated following, of course, 10 or 15 years following liver transplantation. Nowadays, I was involved at the beginning in the late 80s on the development of liver transplantation. So there are now people that have been transplanted for biliary atresia at 1 year old. Now they have 30 years old and they are maybe obese. And I have a pathologist asking for indication for sleeve gastrectomy. Perhaps also Michelle will have a comment on that. Regarding the presentation of Almino, I agree with him that we can perform, let's say, a sleeve gastrectomy that is very close to perfection, because perfection in surgery, it is difficult. It is very difficult, but it is right. Try to achieve it. My comment is that one of the feature of perfection in surgery, in modern surgery, is tailoring, and he has not addressed this point that I think it is very important, because I think the sleeve should be confectioned on the patient need, and I think it's a very versatile operation. And I would definitely say, as Michelle has mentioned, one thing is if we are doing in a super obese sleeve gastrectomy, that is a life-saving operation. To downstage the disease is not the only operation that the patient is going to have. So I think that is the tailoring of the sleeve to the patient is very important concept that I think it might include in his 11 point. Let's say, of course, if you get GERD, you need to give the appropriate operation for sleeve in reflux and hiatal hernia, and of course, it is different if you do a revision sleeve. And the other thing is that I totally do not believe in omentopexy, but I don't think we have data to use omentopexy. If you tell me that you use omentopexy to prevent intrathoracic migration of the sleeve, I don't agree. Most of the sleeve I have re-explored, I found the classic reconstruction of gastrocolic ligament as it would have not been dissected. So the adhesion of the omentum to the sleeve is a natural event. And I don't know, and I'm not aware that omentopexy can prevent leaks or twisting, but this is personal opinion. Going to finally to David Noka, I agree with David on most of the concept he has expressed, and completely agree that sleeve gastrectomy with hiatoplasty, especially in a heavy patient, and especially if you want also to include fundoplication, is a super difficult operation. It's a delicate operation. I have some reservation to the liberal use of Nissen fundoplication with the sleeve. I have the idea that our main topic is to recognize the hiatal hernia in the obese people, because I guess that our problem is not only the GERD, the reflux and the symptoms of GERD, but I have this concept over the last 15 or 20 years that I've been doing bariatric surgery, that hiatal hernia may be asymptomatic, but you do not want to leave hiatal hernia. In my early experience after banding, you do not want to leave hiatal hernia when you do a sleeve, and you do not want to leave hiatal hernia when you do Roux-en-Y, because although Roux-en-Y is an excellent operation for reflux symptoms, you may not want to leave a large part of fundus into the chest of the patient. So if I may project a few slides I've been allowed by the, can I, Manuela, can I project? Yeah, I will choose 2 of the 4 for you. Manuela? No?
Luigi, you need to share your screen.
I did share screen. Share screen. Can you see my screen? No.
Yes, we can see your slides.
Okay, I can't see you. I cannot see them, but I know them. That's fine. So the first slide should be the intraoperative recognition of classic hiatal hernia. This is a case I did a few weeks ago. Simple, if you enter in the abdomen of a patient, see, I think you are seeing, as I understand, the hole into the diaphragm. That's very easy. It's easy to recognize, very easy to recognize that. But you rarely will find a situation like that, because as I think most of the expert panelists and faculty member would agree, the hiatal hernia in the obese subject is masked by the fat that is the fat pad, and this the posterior fat that is going into the mediastinum. So basically you need to suspect most of the patient intraoperatively that they might have hiatal hernia. And here you see if you, Manuela, can I go on?
Yes, please.
You see my second slide?
Yes.
So the second slide is a dissected hiatus. So basically, when you suspect that there is a hernia, you need completely dissect the right and left crus. And this is what I often found, not a small defect, a big defect. And you need to see the starting, the V of the crus to repair it appropriately. And you must repair, in my experience, quite tight. You need to repair. What I use now is a non-absorbable V-lock in a continuous fashion. Can you see my continuous suture? No?
No, I don't see anything, Luigi, but perhaps I can, since
you don't see my slide, Michel?
No, but
I show them to you privately.
Too many questions. I would like to start answering on the Roux-en-Y gastric bypass. Dr. Cao, can I answer?
Yes, of course you can, Michel.
Yeah. So I didn't, perhaps I did not hear correctly, but you said a biliopancreatic limb of 250?
200. Yeah, 200.
Yeah. Well, you know, recently in the team of UK, I think, has published a randomized control trial looking at single anastomosis gastric bypass between 150 and 200 centimeter BP limb. and they saw no difference in weight loss, but more micronutrient problems with a BP lim of 200. So I would not, I think it's dangerous if you go beyond 150 centimeter of biliopancreatic limb, and I would not advocate a longer BP limb just because you're worried that your Roux-en-Y after sleeve is not going to give you good weight loss. I think you have to really, really be careful, because you're going to get micronutrient problems, and you may have to go back and correct this, because probably you have to measure the total length of the intestine. And if you have a shorter common channel, you can put your patient at big trouble. My comment was Roux-en-Y gastric bypass for reflux, and I would rather do a CD for someone rather than attempting to do a very distal Roux-en-Y gastric bypass and getting more micronutrient problems, because in a CD you have a much bigger stomach, and this is a better proposition when you do hypoabsorptive surgery. This is the overall concept of going back to scopinaro at adduct stomach. You need a bigger stomach when you go more distal in common channels. So I don't know.
So Michel, would you advocate in a patient, let's say the classic super obese patient has a sleeve gastrectomy, after 10 years come back to you with a reflux, with a part of the stomach into the chest and weight regain? Would you go for a mediastinal dissection, hernia reduction, and SADI better than Roux-en-Y? This is your message, as I understand.
First of all, there is this notion that putting someone on PPI is a bad thing. Actually, there are hundreds of millions of people worldwide on proton pump inhibitors, and actually, I think it's a good drug. So don't think that you have to solve everything by surgery. If this is a discussion that goes on with each individual patient, what is the number one problem that we need to solve here? Is it the reflux or is it the weight loss? And you can still continue on PPI. In fact, if you look in France, when they do Roux-en-Y gastric bypass, or if you look at the Karolinska Institute study on Roux-en-Y gastric bypass used for reflux, 5 years later, 50% of them are back on PPI. So you've got to be thinking, if you're going to solve the reflux with Roux-en-Y, you're only going to solve 1 out of 2 cases, and the patient will still be on PPI.
Michel, you are changing 100% my fundamental concept but with this advice, because my idea was at least to try to solve most of the problem. But you may be right. I disagree, but you may be right.
Right. Luigi, you brought in a number of questions. Perhaps we'll quickly answer each one of them. Almino, omentopexy.
Yeah, Luigi asked and pointed very well to 2 situations. One is about tailoring, and this will put us back to this discussion. I agree with the comments of Michel and Luigi, but I continue thinking that the best procedure, if we have esophageal, if we have GERD, it is Roux-en-Y gastric bypass. So I prefer to go to a more distal gastric bypass, using looking for all the length of the bowel, increasing our biliopancreatic limb, decreasing the common limb, in order to improve the results of the procedures in terms of weight loss. But I prefer, in the case of hiatal hernia and reflux, to move from gastric bypass, then SADIs or other procedures. And about omentopexy, I also agree with Luigi. This is controversial, but based in my experience in the revision of some cases that I could see, in our cases, in my 2 or 3 years practice in the beginning of sleep. When I revised the patient for different reasons, I could see a lot of adhesions from liver and the stomach, and these adhesions will turn the position of the tube, will twist the tube. So my proposition about omentopexy is not to avoid bleedings or leaks, it's just to align the position of the tube, avoiding twisting and kinking.
Okay, David Knocker. Luigi asked you about reflux. Listen. David, turn on your microphone.
Microphone.
No, David, turn your microphone.
I think it's okay. So I don't remember the question. I think that I'm totally agree with Luigi. I think one of the mistakes that we have done at the beginning of the learning curve of the sleeve is to don't check for a hiatal hernia, because it's very difficult for gastroenterologists to tell us if there is, before the operation, a hiatal hernia or not. And what is the explanation of GERD after sleep? There is, for me, two problems. The first is a hyperpressure system of the sleeve. It is probably due to a mistake, a stenosis or a twist. It's the first option. The second is that I think a lot of surgeons let in place a hiatal hernia. And if you have a hiatal hernia, the sphincter has not the same pressure than for abdominal position. So that's why I'm pretty sure today that we have to evaluate in a international multi-center studies the Nissen sleeve for low BMI. Why? Because it will not be easy to promote this operation above 50 of BMI. And I think one of my mistakes as the beginning of the learning curve was to try to simplify the operation in order to spread it. We had a lot of complication in 2017 because one of the experts in the Ifso meeting told me, "Hey, David, why are you releasing the hiatal space when there is no hiatal hernia for doing a Nissen sleeve?" I was thinking, hey, perhaps he is right. So I try to fix the fundoplication on the esophageal junction and not on the lower part of the esophagus. And it was a mistake because the food was trapping on the wrap. You understand? And we had dilatation, and we had 10 cases of perforation of the wrap. Since 2 years, when you put the wrap on the esophagus, when you check during the operation with the tube the good way of the food, the rate of morbidity is very low. It's less than 3%. So for me, we really need today to promote the evaluation, large evaluation of this operation for BMI between 35 to 50. And I think it's better to have experts first that will do the evaluation. After that, we have teach for bypass surgeon. We have teach for SADI, for duodenal switch. It is very complex procedure. And I think we will teach for Nissen sleeve other surgeon. But I think we need experts. And I know that Michel, that Bruno Dillman, that Almino, Patrick, Mariano, they have already done some. But we have tips and tricks to spread. I have done some mistakes, and I don't want you to do the same. But today I'm very I'm convinced of this operation more and more, and I think there is a place for it.
So can I just ask you, David, you think that Nissen fundoplication is out of the learning curve in your hands, that it is a standardized procedure that is ready to be spread around the world?
Yeah, since 2 years, I told you we had begun, it was 2013. We have done 500 cases, and we had a good learning curve during the first years. And when I try to simplify the operation, to try to save some time, to don't release the hiatal space, I had the complication. It's always the same thing. Remember with the sleeve, at the beginning of the sleeve, nobody has leakage. Why? Because we were doing large sleeve. Then 5 years after, we had a rate of leakage because everybody wants to have effective sleeve in terms of weight loss. So I think since 2 years, we have done more than 250 cases, and I sent the paper to obesity surgery. We had less than 3% of complication and no more leakage, no more leakage. And in September, I will have the result of 5 years follow-up for GERD. So really, I think since 2 years it's okay, and it's time to promote studies, multi-center studies, and to spread a little bit the technique, because I told you I'm convinced that the rate of internal hernia is underestimated for bypass. I don't know in France, but we had a lot of cases of internal hernia. We had abdominal pain after bypass that we don't reoperate because we don't see the hiatal, the internal hernia. And I think it's better to do a Nissen sleeve when the patient had severe GERD before the operation than a bypass. I have to be honest. And if you have a failure after a Nissen sleeve, you can do a SADI, you can do a SASI, you can do whatever you want. If you have a failure of bypass, I still don't know what I have to do for my patient.
And a very final question. Would you consider to do a randomized trial of Nissen sleeve versus classic, let's say, Gagne sleeve with hiatoplasty?
No, what we have done, and it will be September. What we have done, and it will begin September 1st. It is a randomized study between Nissen sleeve and sleeve without hiatoplasty for all the patients. So I will tell you why.
But
the problem if you want to do a random
here.
Sorry?
I think that we know that sleeve and hiatoplasty alone is not giving good long-term results. So that's not the proper one to do. In my opinion, the big question is the Nissen sleeve versus Roux-en-Y gastric bypass.
Yeah.
And looking at the Karolinska Institute data, which a lot of people haven't looked at, there is 50% of Roux-en-Y that have failures for reflux and are back on PPI. So because you do nothing to the barrier of the sphincter. So it will be interesting if David's operation will block the reflux over time because of the fundoplication. And this may be a better operation than doing a Roux-en-Y gastric bypass for reflux in these patients.
I think this is step one. The step one is to compare Nissen sleeve to bypass in a randomized trial. And the second one, and in the future, I think, will be to evaluate if for patient without reflux before the operation, because we have seen on different studies that the rate of reflux, de novo reflux, is around 10%. So I think first is to evaluate compared to bypass, and then we will see after the indication. But I have to be honest, in my team today, I propose all the operation sleeve, Nissen sleeve, and bypass to all the patients, not only Nissen sleeve for severe reflux, to be honest.
Okay, I'm going to ask Mel before we come on as well.
You have to be, you have to then understand. I told you, you have 10% de novo reflux after sleeve. You have seen it, you know that. De novo reflux, it exists. So if I have a procedure with the same weight loss, less complication, less leakage, why I will not give it to my patient? Tomorrow, if I can prove, listen to me, and after I stop, Tomorrow, if I bring a study to you, I told you I have the same weight loss than sleep at 5 years. I have less than 10% of reflux, and I have 0% of leakage. Will you give you this operation to your patient or not?
I agree with you. I agree with you. I agree with you. But to be frank, to be honest with you, I recently had a case of a lady between 32 BMI, quite old, with severe reflux. They wanted to have a sleeve, and I proposed to do the Nissen sleeve. Just to show you that I'm open to the use of it, although I have some reservation regarding the technique, because I'm not, I mean, I'm sure in your hands, the leather is
I have
complete.
5 fingers. I have only 5 fingers. You have the same hands on you, you know. Now, I think the other point is for young people. For young people, when you are doing a sleeve, you have a risk of reflux. And I think if we can promote the prevention of GERD, it's better. So we have to see in the long run. But today, I think in 2 years, the procedure is standardized. We have the long-term follow-up concerning weight loss and GERD treatment, prevention. Then we just need to compare with bypass.
I'm just waiting for Michel doing it. I want to see how Michel does it. I always do procedure after him.
I have to be honest. I had to go to Montreal. It was April, but we had the COVID, so I think we will do it in next March or something like that. But it's too cold in the winter in Canada for me.
Thank you very much. I'd like to invite Mel Phoebe as well, who is one of our panelists. Mel, can you turn on your webcam?
If I can, is that it right here? Share.
Mel, have you got any comments? You are on.
Okay. Very nice presentation about the sleeve. I enjoyed all the presenters and the various points that were made. Comment to starting with Dr. Almino's talk, which was an excellent demonstration of the sleeve. The only thing I question or I have a comment about is the use of staple line reinforcement routinely. That can be done using a clip. But again, that's a question of choice. The question I have for him is, how far from his pylorus does he start his antral transection? Because it looked like he had a big antrum there when he finished. For Dr. Noel, an excellent presentation. However, he listed a sleeve as a preferable procedure for patients on anticoagulants. I experienced at Mohawk in India, where we've done thousands of sleeves, is that the incidence of bleeding after a sleeve is higher than after a gastric bypass. So if I have a patient on anticoagulants, I'll be less likely to use a sleeve. Dr. Noka has a very nice presentation. I get the impression now he's trying to propose that we do the Nissen plication routinely in sleeve patients. Or should we not just do it on patients who are symptomatic or have endoscopic findings of GERD? Or does he want to do it routinely? Because my personal experience with a sleeve and working out of a center where we've done 3,000 sleeves and looking at the long-term follow-up, even though the reported rate of revision is 6 to 12% as quoted by Dr. Gagne, but the failure rate, it's approaching 50%. What I mean by failure rate is inadequate weight loss, at least below 50% excess weight loss. So there are times when we look at publications and we talk about the revision rate and try to equate it with the failure rate or the non-responders as a better word. the non-responders after the sleeve, if you look at it from many large series, ends up having anywhere between 35 to 50% of the patients who have less than 50% excess weight loss. I know there's a subjective question, the patient might be happy with it, but again, if we want to make anything objective, then that's something we have to consider. Dr. Polamo had a very nice presentation. It's just that he put three different terms together and I kind of got confused. He talked about early and late leaks, and then he talks about acute and late leaks. So most of us define early leaks as anything less than 30 days and beyond 30 days late. But I agree with him that the rate of leaks in the sleeve well done is very low, about 1.5%. Michelle had a very nice presentation again, as usual, but I look at the number of gastric bypass done in the United States, and if we have 50% of the patients with reflux coming back with reflux, for some reason we're missing it, or there might be the possibility that a lot of patients after gastric bypass in the United States are still taking PPIs. I don't know that information, but that opens up room for research since we have such a large database in the NetScript. A young surgeon, one of these might want to look at the number of patients who are on PPIs after a gastric bypass. I do agree with him, however, that the gastric bypass is a poor revision operation for the sleeve, because the cases where I've seen the sleeve revised to the gastric bypass for any reason, the weight loss is about the same as was with the sleeve. It does relieve the GERD, but not increase the weight loss. Finally, I would say I'm remiss after I read through the book to see that the idea of using a ring to stabilize the pouch size was not even addressed in the whole book. Michelle gave a very good presentation that the sleeve starts out at about 90 to 120 cc's, and by natural history, in a year goes up to about 300. And most of the reasons that sleeves have poor response is because of the increased volume. Placing a ring proximal in the proximal pouch controls that aspect of the volume, and results and some prospective studies that have been published document that, and that would decrease the rate of non-responders. Otherwise, it's been a very nice presentation. Because I think the ring gastric bypass with an increased BP limb of 100 to 150 cc's is the best revisions operation for the sleeve, and we have a paper that is being submitted to that effect. Again, thank you very much for having me as part of this interesting forum.
Well, thanks, Mel, for your comments. Perhaps we'll have some quick comments from the speakers, and then we have a lot of questions that have been put forth by the attendees. So very quickly, Michelle Garnier, the ring and the sleeve.
Yeah, can you hear me okay?
Yes, we can hear you.
Yeah.
Something that I wanted to point out to Mal, even though there is a lesser percentage of excess weight loss over time with sleeve, you have to be cognizant that the operative mortality of Roux-en-Y gastric bypass is twice the operative mortality of sleeve. That is the first problem. The second, from Korkulas from Pittsburgh, they have followed the patient's sleeve or bypass, and over a period of 5 years have shown that the mortality is 50% higher on patients who had a bypass versus those who had a sleeve. So that is quite interesting. And the mortality comes from intestinal problems, bowel obstruction, and other problems related to reintervention. So we may have an operation that has slightly less percentage of excess weight loss, but at least if we look at survival over time, it might be still better. So that's my question mark. Also, we're facing millions of people, the obesity is increasing, and if we have an operation that has a worldwide impact, I think we should be doing 5 million to 10 million, 5 million patients a year. We need an operation that is quick, less morbidity, less mortality to do, and then do intestinal surgery for those who really need it. Now, the PPI in Roux-en-Y gastric bypass, this is known in France because France has a national institute, a national healthcare system, and also the drugs are reimbursed by the state. So we know that Roux-en-Y gastric bypass patients are taking PPI. At least 1/5 of them are back on PPI 2 or 3 years later after their Roux-en-Y gastric bypass. The 50% that I quoted was patients who were operated specifically for reflux,
Okay.
And then the ring, I don't know why we didn't put the ring, but I agree with you. It should be, we should have had a chapter. But you know what? I think the book is so popular, we'll get a second edition and we'll invite you to write that particular chapter.
Thank you.
Well said. Almino Ramos, reinforcement.
Yes, let me do something right now in honor to Malfobi. Thank you, Mal, for your considerations, and we are approaching the end of the webinar, so let me thanks the co-editors of the book, Michel Gagné, Mariano Palermo, Noca, Noel. Was a great honor to work with you in this book. And thank you to Luigi, Mau, and Manuela for the support for this webinar. I think it's very important when we talk about perfection, we can see that any case could be perfect, but they will be different. So it's important in the end of procedure to think, could I do my best for this patient? So if you think that you could do your best for that patient, I think you did a perfect job. You did the best you could for the patient. And regarding the comments of Mao, I always try to start 2 to 4 centimeters from the pylorus, and we cannot see the video again, but look here, Mo, I am 2 or 3 centimeters from the pylorus. That's the idea. And about reinforcement, I think that all of the surgeons agree that we should reinforce. No matter you use suture, Singward, or if you look for any point of bleeding that you put a clip is also to do some reinforcement. So we are reinforcing as we see that the patient will need some reinforcement. And good, thank you. I think that's my final comments in this webinar. Thank you so much.
Thank you, Almino. Is Patrick Knowles there? Patrick, can you share your screen? Patrick, Mel wanted to ask you about anticoagulation. What are your comments on that?
Nobody answered me also about sleep after liver transplantation.
Patrick.
Patrick?
Need your microphone on.
Unmute. Have you done, Michel, sleeve after liver transplant?
Yeah.
Open or laparoscopic?
Laparoscopic.
That's
Kidney
doable.
after kidney, after liver, after heart. Yeah.
Yeah.
Okay, Patrick, have you got your microphone on?
We can move on to another time. We're running with
Okay.
time.
There are a number of questions from the attendees. One from Semi Mansu. What's the definition and role of the pyloric preserving sleeve? Does it affect weight loss or leak rate? Who would like to answer that?
They are all caloric
Caloric
preserving.
preserving sleeve. Okay. From Maruf Khan, do you close the port side to prevent hernias?
For
Just
us,
the big one.
only the umbilicus.
Yeah. Just the one that he used to remove the sleeve.
Yeah.
All right. From Jack Himpens, portal vein thrombosis
Hey,
is a
Jack.
complication. Portal vein thrombosis is a complication typically linked with sleeve gastrectomy. Isn't this a negative argument for cirrhotic and pre-transplant patients?
Yeah.
It's May. The rate is very low, but it's true that we have some cases of portal vein thrombosis. So I think we have to evaluate the patient and the risk of the patient before, and because I think the procedure and the adhesions of the bowel has to be evaluated if you want to promote a bypass after liver transplant. It may be difficult by laparoscopic approach if there is a lot of adhesions and you have still the problem of drugs intake, and that has to be very checked after the operation to don't have a problem with that for malabsorptive parts.
Okay, Martin Suswin wants to know. Sorry.
I don't think it's. I think it's been documented with other laparoscopic procedures, especially bariatric. You've seen it after bending, after Roux-en-Y gastric bypass, after switch. But it's true in sleeve we see it more frequently, and I think it has to do with some dehydration post-op that is more frequent than, let's say, Roux-en-Y gastric bypass patient where the anastomosis is wide open. Recently, I got an interesting case, a patient with inflammatory bowel disease who had a total protocolectomy and developed portal vein thrombosis after surgery. She comes back to me now with morbid obesity and wants to get a sleeve. What should I do? And I did a CAT scan with contrast, and the portal vein is totally recanalized. Everything is back to normal. So I'm a bit worried about getting another one, but I will fully anticoagulate it. Whatever I decide.
You may propose gastric banding, adjustable gastric banding.
No.
Okay, I have another question from Rodolfo Maquilarina. Have you ever had a torsion or twist of the sleeve under Nissen plication? And you have, how do you manage this complication?
So for Nissen sleeve, I think the question is, no, we have complication, specific complication of the Nissen sleeve. It is the dilatation of the wrap due to a bad trapping, a bad way for the food. So you really need to, I told you to fix the wrap on the esophagus and to check with the tube at the end of the operation that the tube is going through the sleeve and not through the wrap. This is the point. The second specific complication that you may have, it's gastric perforation at the level of the fundoplication. There is two possibilities. The first is the damage by the grasper of your assistant during the creation of the wrap. So be careful, don't damage the gastric wall. The second is the thermic injuries with harmonic or with other devices. So you really need to be a little bit away from the gastric wall when you do the release of the fundus in order to avoid damages. After, you may have some mistakes, but it's the same than for a normal sleeve. If you have complication at day 1, at day 2, at day 3, you just have to do a cilioscopy and then to remove the wrap, and you solve the problem. But the thing is that you have to do a very quick diagnosis of the complication because sometimes it may be difficult and you have peritonitis at the upper part of the abdominal cavity. So no twist of the wrap. We had 2 cases of wrap migration in the chest, but without symptoms, and the patient are okay. So we did not reoperate the patient.
Okay, from Mark McD, there's a question for Dr. Garnier. Dr. Garnier is offering SADI for patients after sleeve gastrectomy with reflux. Is reflux not considered a relative contraindication to SADI?
No.
Well, again, this is a discussion, as I said, with the patient, and what is the most important problem? Is it the weight or is it the reflux? If the patient has mild reflux and is not taking regular PPI, I would consider SADI without any hesitation. In fact, in the study comparing from Dr. Busing, comparing SADI and single anastomosis gastric bypass, he saw an improvement of reflux after SADI. So this is an interesting concept. But if the patient is agreeing to continue the PPI and doesn't seem to worry about this, I think it's, we've been doing duodenal switch for 20, 30 years with reflux, and these patients are on PPI, and it's not been such a problem. So if the reflux is #1 problem and the weight is becoming secondary, then I would agree that Roux-en-Y gastric bypass is the primary procedure. So it's a talk with the patient. I don't have a magic answer on this.
Okay, Patrick, no. Is your microphone working now?
Yeah, it's working now. So to answer to Mal, when you are doing a bypass, whatever the bypass, it's possible to see a marginal ulcer or an anastomotic ulcer. If you are under anticoagulation, there is a higher risk of bleeding. And second thing, if you do a sleeve, you don't have this risk, obviously. And we know that there is an improvement on the absorption of the anticoagulation medication with a sleeve as well. So for all this reason, I prefer to go for a sleeve. And because we can use as well a reinforcement to limit the risk of bleeding over the staple line. So for all this reason, I think sleeve is a good option with patient under anticoagulation.
Thank you.
Okay, thank you.
I had another question with regarding transplantation. Oh, nice picture. Regarding transplantation, we know that there is several guidelines stating that the patient should be with a BMI less than 30 to go for transplantation, abdominal transplantation, like kidney or liver transplantation. So we know that I'm not drunk. We know that a good weight loss may make a transplant surgery technically easier. So reducing as well the perioperative surgical risk. So for this reason, I think doing a sleeve gastrectomy before a kidney or liver transplant could be a good option, and probably is a safer option than doing a gastric bypass. And last comment, we know that obesity and diabetes are the 2 major factors reducing liver transplant survival. At 6 years of follow-up, we have data now with liver transplantation. For all this reason, it's important to lose weight. Sleeve is probably the safer option. You can do the sleeve before the transplantation. I know some team try to do the gastric sleeve during the transplantation, but I think it's not I don't like this concept. And other team try to do a sleeve after the transplantation. I think for all these different reasons, sleeve should be a good indication before an abdominal transplantation.
Great. Mariano Palomo, we had some questions for you. I think Mel wanted to know about acute and chronic leaks, but I can't remember his question.
It's just a question of definitions.
I think he did ask you that. You need to put your microphone on, Mariano. Okay, while you're working on your microphone, there's a question from Jack Himpens. Wouldn't you agree it is wise to err towards a greater staple height? Bleedings can be addressed during the procedure, but leaks will stay with you for a long time. That's why I use black loads all along.
Absolutely correct. The shorter staple height also causes crushing of the tissue and increases the rate of leaks.
Okay. I have a question from Ihab Mahom. Did you study ghrelin values after sleeve Nissen compared to sleeve only?
I think I will be obliged to do it because everybody speaks about ghrelin, but the question is, do you really think that ghrelin explains the weight loss after bariatric surgery? I don't think so. Ghrelin expects the feeling of patient to don't be hunger, but don't explain the weight loss. When you are doing a bypass, okay, you don't remove the fundus. You let the fundus on the left of the stomach. So I will do it because everybody, a lot of experts ask me for this question, and in the next study we will evaluate it. But explain to me why I will have a bad effect on ghrelin compared to bypass. During the bypass, the fundus is still there. The food will not go through the fundus to the bypass, but it will not go through the wrap too. So we will have the same effect, I think.
Okay, thank you. I think we should wrap up very soon. So I'm going to ask for one sentence statement from each one of the speakers to conclude this session. So we'll start with Patrick Noel. Have you got a concluding statement for our attendees?
So I really think that today, even it's difficult to state it will be a perfect sleeve, as Ramino told before. We do our best. Sleeve today is a very, very safe procedure with less, I saw the last figures, less 0.5% of risk of leakage. It's an effective procedure. We have very good long-term result, over 70% at 7-10 years. The last issue is the reflux, and as David told, we have solutions now, like Nissen sleeve could be a good option. And when you have a weight regain, like with every procedure, after a sleeve, it's easier to go for a second surgery. You have all kind of bypasses, and Michel explains the algorithm with re-sleeve gastrectomy in some indication, with SADI, and sometimes one-way gastric bypass when you have a severe acid reflux. So for all these reasons, I really think that today's sleeve, like a majority of surgeons and patients, is the first procedure of choice for bariatric patients.
Thank you. David Knockel, short statement.
Yeah, short. One word. The word is freedom. Freedom for surgeon to choose whatever they want to propose to their patient. I think we want all to give the best to our patient. We have not all the same feelings, but I think the main target is not to fight against people who are doing mini bypass, who are doing bypass, who are doing SADI. This is not the fight today. The fight today is to explain to the world that obesity is a disease and that the surgery is a solution for a lot of patients. I think in France, we try to promote this with a league against obesity to explain to the patient the risk of obesity. We have seen with the COVID that the increased rate of death for obese patients. For the technique, I'm totally agree with Patrick. Today's sleeve presents the best balance between benefits and risk. I will continue to evaluate and to give you the result of the Nissan sleeve because it may help, but freedom is the solution.
Okay. Mariano Paloma, are you there? Can you share your webcam? In the meantime, while we wait for Mariano, Elmino Ramos, you've got your Ifso hat on again.
Yes, again with Ifso. At night, I will be with the head of Mao again, head to head. So guys, this webinar is about a sleeve gastrectomy and perfection. We are talking about surgery. We are not talking about a building, a bridge, something that comes from engineering. So to go closer to the perfection will depend on your experience, your skills, your training. We have here now in the monitor, we have Michelle, Noka, Noel, Mal, and we have different experiences. We have different skills. We work in different countries. So the definition of perfection for us could be different. So what I think we should do is try to do your best for every case. Try to do the best you can for that patient. And for that patient, you will reach your perfection. Thank you so much.
Okay, and Michel Garnier.
Well, I think the thought was to have a procedure that could be done worldwide, and I think we're not doing enough. As you know, only 1%. Some countries only 0.5% of all the candidates, and with COVID-19, we've seen that obesity is a big risk factor for mortality. I think we should be doing 5 million procedures a year. I hope we can ramp up and do the procedures and reserve intestinal surgeries only for those who needs it. That's my message, and I think sleeve at the moment seem to fit the criteria for a worldwide rapid diffusing procedure.
Thank you. And lastly, Mariano Palomo, you got a statement for us before we finish?
A few words. First of all, to answer the question to Malfobi regarding the early acute and all those things, I think it's okay. The acute one are up to 7 days, and then it's okay. 30 days and less are early, and the other ones are late. And my final comment, it's I would like to thank Almino for the idea of carrying out this book, Patrick and David, because both of them are very close friends, and it's an honor for me to share science and friendships with both. And David, I always remember the first time we saw each other in Avignon in 2006, and you opened me the doors for many things, so I'm very, very thankful for that. And the big Michel, I met Michel in 2003 at Mount Sinai in New York, then Cornell, then Mount Sinai, Miami. I follow him everywhere, and thank you, Michel, for your friendship and for your mentorship.
Well, it's been my pleasure to be moderating this session with such an esteemed faculty. I'd like to firstly disclose that while we promote your book, Ifso's got no commission on the sale of your book, but this session has been supported and sponsored by Reach Surgical. So thank you, Michelle Amino, David, Patrick, and Mariano for being the panelists, for being speakers on this webinar. Thank you, Mel Phoebe and Luigi Angrisani for being such good panelists. We planned for a 90-minute webinar, and I think we've gone way beyond our 90 minutes. So thank you to all the attendees who have stayed with us for all this time. And once again, we'll meet soon, but thank you again for such a stimulating session. Thank you very much.
Thank you.
Thank you, David.
Thanks to you, Lilian. Bye-bye. Thanks to everybody.
Pleasure.
Very much.